Imagine going to the doctor because you just feel violently ill. Your stomach is in knots.
Right, you're dizzy.
Yeah, dizzy, you can barely stand up. And instead of giving you something to, settle your stomach and bring you some relief, the doctor hands you a potent liquid specifically designed to make you throw up.
Which is, it's the fundamental paradox of medical history when it comes to this topic.
It's completely wild to think about today.
It really is. For hundreds of years, the medical establishment wasn't trying to stop vomiting at all. They were actively, intentionally trying to cause it.
And that historical disconnect is exactly why you, the listener, and the two of us are jumping straight into this deep dive today.
Oh, absolutely.
We have this massive stack of pharmacology notes, medical history, and clinical research data sitting right in front of us. And our mission today is to unpack the science of antiemetics.
Basically, the highly complex drugs designed to stop nausea and vomiting.
Right. Because if you have ever been truly nauseous, you know it is just a universally terrible, all-consuming feeling.
Oh, the worst.
But as these sources reveal, treating it is incredibly complex. We so often treat nausea as this one single monolithic problem.
Right, like a single symptom.
Exactly. But in reality, it is a massive multi-pathway alarm system running through your entire body.
Okay, let's unpack this. Because to understand how we actually stop vomiting today, we have to look at why doctors of the past viewed the act of throwing up not as the enemy, but as the actual cure.
Yeah, so the rationale for that was rooted deeply in humoral theory.
Right, the four humors.
Exactly. For most of documented medical history, the prevailing scientific idea was that sickness was caused by an imbalance of fluids or humors in the body.
So if you were sick,
the logic dictated that you had an excess of a toxic or corrupted humor. Therefore, the absolute fastest way to restore that balance and, save the patient was to aggressively purge the body of those bad substances.
and they did this using emetics, like ipecac syrup.
Yeah, ipecac was a huge one. So you were already miserable, and they deliberately gave you a chemical to make you retch even more.
It sounds like torture to us now.
It really does. So when did the paradigm finally shift? When did modern medicine decide that keeping our lunch down was actually a worthwhile therapeutic goal?
Well, the shift toward preventing vomiting really only gained urgent momentum in the mid-20th century.
Okay.
Two major medical advancements kind of collided to force this change. First, you had the widespread adoption of general anesthesia for surgical procedures.
Right.
Early anesthetics reliably caused severe, violent vomiting as a postoperative side effect. And that was incredibly dangerous for patients who were just recovering from major surgery. You don't want someone heaving when they have fresh incisions.
Wow, yeah, that makes total sense.
And second, it was the early days of cancer chemotherapy.
The notes detail this pretty heavily. They talk about how chemotherapy caused nausea that was so severe, so physically debilitating, that patients were literally refusing further life-saving treatments.
Yeah, they were choosing the cancer over the cure.
Because the vomiting was just that horrific.
Exactly. So suddenly, the medical field is desperately motivated to stop this process. But they immediately hit a brick wall.
Because of a massive neurobiological myth.
Right. See, pharmacologists and neurophysiologists back then, they were operating under this assumption that vomiting was controlled by a single anatomical vomiting center located in the brainstem.
Like a literal button.
Exactly. They viewed it as a discrete biological button. The thought was simple. If we could just find a drug to push that specific button, turn it off, we cure nausea.
Bam, problem solved.
Right. But by the 1990s, modern imaging and neurophysiology kind of forced science to completely abandon that single-button model.
Because as it turns out, it's not a single button at all.
Not even close.
The modern understanding describes it as a central pattern generator, or a CPG.
Yeah.
And thinking about this, it's kind of like a symphony conductor.
That's a really good way to look at it.
You don't just have one single instrument playing a solitary note. You have this maestro, the CPG, which is actually a highly distributed network of neurons scattered all throughout the medulla in the brainstem.
Right.
And this maestro is tasked with coordinating an entire complex orchestra of muscles. It has to perfectly time the diaphragm, the abdominal muscles, the stomach, the esophagus, the airways, conducting them all into this highly stereotyped, perfectly synchronized sequence of retching and expulsion.
What's fascinating here is why this distributed network model matters so crucially in a clinical setting.
How so?
Because the central pattern generator is a sprawling network receiving incoming signals from multiple, completely separate input pathways across the entire body. You cannot just flip one master switch to turn the whole thing off.
Oh, I see.
A drug that blocks an incoming signal from one specific pathway might do absolutely nothing for nausea that is being triggered by a completely different pathway.
Which leads to a really obvious question, I think. If the CPG is the conductor of this terrible orchestra, how does the conductor know when to start the music?
Who is sending the signal?
Exactly. Wait, let me rephrase that. If this trigger zone is in the brain, how does it know I just ate, like, a bad piece of fish?
Right.
Because the brain is heavily walled off. It's protected by the blood-brain barrier. It shouldn't be exposed to whatever I just put in my stomach.
Well, the anatomy actually dictates this brilliant biological workaround.
Okay.
Between 1949 and 1953, you had these two physiologists, Harold Borison and Sam Wang. They made a monumental discovery while doing some early anesthesia research.
What did they find?
They mapped a specific region in the medulla called the area postrema, and they designated it the chemoreceptor trigger zone, or CTZ.
The CTZ.
Yeah. And to answer your question about the bad fish, the defining feature of the CTZ is that it sits just outside the blood-brain barrier.
Oh, wow. So it's basically dipping its toes directly into the bloodstream.
Precisely. It acts as the ultimate biological sampling system. It continuously monitors your circulating blood and cerebrospinal fluid for foreign toxins or poisons.
Just constantly checking for danger.
Exactly.
Yeah.
And the moment it detects a high concentration of a noxious chemical, it fires an intense chemical signal directly to the central pattern generator. And then that expulsion sequence begins to physically remove whatever you ingested.
That is incredible. So Borison and Wang successfully give pharmacologists an actual anatomical target, the CTZ.
Right.
But then we hit 1950, and the story takes a wildly serendipitous turn in the notes because we get a French chemist named Paul Charpentier and a surgeon named Henri Laborie, and they basically stumble into a cure.
They really did.
Am I reading this right? So you're telling me the first major drug for this wasn't even designed for nausea. It was just a happy accident during surgery.
Yeah, the discovery was a profoundly happy accident. So Charpentier had recently synthesized a novel chemical compound called chlorpromazine.
Okay.
And he was not looking for an antiemetic at all. He was purely searching for a better, more potent antihistamine to use as a preoperative sedative.
Just to calm people down.
Right. So Labor took this new compound and started testing it in patients as part of a pre-surgery cocktail just to chill them out before going under the knife.
And he notices that not only are the patients calm and indifferent to the stress of surgery, but crucially, it completely suppresses their post-operative vomiting.
Yeah. Labor's observations literally changed medicine forever. We later learned that chlorpromazine was working by aggressively blocking dopamine D2 receptors.
Okay.
And those receptors are located right there in the chemoreceptor trigger zone that Borison and Wang had just mapped.
So it was blocking the signal at the CTZ.
Exactly.
Yeah.
Chlorpromazine actually went on to become the very first antipsychotic drug, which inadvertently launched the entire field of modern psychopharmacology.
Wow.
But its incredible power as an antiemetic was discovered entirely by accident.
So it proved that we could successfully intervene in the body's vomiting pathways using chemistry. But chlorpromazine was specifically targeting the brain's toxin detector. The glaring issue, according to the sources, was that medical science was about to learn that some of the most severe, relentless nausea doesn't start anywhere near the brain.
No, it doesn't. The next massive leap forward required looking far away from the medulla.
To the gut.
Yeah. The development of the 5-HT3 receptor antagonists, the serotonin blockers, is arguably the most significant pharmacological antiemetic discovery the last 50 years.
Here's where it gets really interesting. Let's break down the mechanics of this because the sources are incredibly detailed about the cellular level here.
Sure.
Researchers in the 1980s realized that cancer chemotherapy was doing something very specific and very violent in the small intestine.
Right.
The chemotherapy was physically damaging these specialized cells in the gut lining called enterochromatin cells. And when these cells get damaged, they essentially panic. They dump massive, overwhelming amounts of serotonin directly into the gut tissue.
Exactly. And that localized flood of serotonin binds immediately to 5-HT3 receptors.
Okay, and where are those?
These receptors are located on the terminal ends of the vagus nerve.
Ah, the vagus nerve.
Yeah, think of the vagus nerve as a massive, high-speed information superhighway that physically connects the gut directly up to the brainstem.
Got it.
The serotonin triggers a distress signal that travels at lightning speed straight up that nerve highway and slams directly into the central pattern generator.
It's like a fire alarm being pulled down in the basement, but the sprinkler system goes off all the way up in the penthouse, the brain.
Yes.
For years, doctors were just spraying water in the penthouse, wondering why the smoke wasn't clearing, completely unaware that the brain was simply reacting to a massive, localized crisis happening in the basement.
That is a perfect way to visualize the mechanism. It is a gut-first phenomenon. And finally, mapping this pathway changed the landscape of oncology forever.
Because before they figured this gut mechanism out, chemotherapy-induced nausea and vomiting, or CINV, was a living nightmare.
It really was.
The sources highlight this deeply psychological phenomenon called anticipatory vomiting. What exactly is happening there mechanically?
Anticipatory vomiting is just a tragic demonstration of Pavlovian conditioning within the human cerebral cortex.
Like Pavlov's dogs.
Exactly. The nausea from early chemotherapy was so violently traumatic that the brain would form deeply entrenched neural associations.
Just out of pure trauma.
Right. Patients would begin violently retching just from the smell of the hospital lobby or seeing the nurse who administered their fear, or even just thinking about the infusion room days in advance.
That is heartbreaking.
It is. Before a single drop of chemotherapy had even touched their veins, the higher cortical memory centers of the brain were independently triggering the CPG based entirely on severe anxiety and trauma.
But then enter the drug ondansetron.
Yes, ondansetron.
Approved by the FDA in 1991, developed by a team of researchers at Glaxo. This drug was engineered to specifically target and block those 5-HT3 serotonin receptors on the vagus nerve.
Effectively cutting the wire on that basement fire alarm.
Exactly, and it completely transformed cancer care. Today, ondansetron and its chemical relatives are the absolute gold standard first-line defense for chemotherapy nausea.
But the discovery of that gut-first mechanism brings us to a massive, fundamental misconception in medicine.
Oh yeah, the notes really stress this.
It completely shatters the idea that all antiemetics work the same way.
I want to underline this point for you listening because this was a massive aha moment for me in the research. Antiemetic is not an actual chemical family of drugs.
Not at all.
It's a purely functional label. A drug earns the title of antiemetic simply because it stops you from throwing up, not because it shares any structural chemistry with other antiemetics.
Right.
It's like classifying a hammer, a screwdriver, and a stick of dynamite all in the same exact tool family, just because they can all technically be used to open a locked door.
That's a great analogy.
There are at least 6 structurally unrelated, distinct drug classes out there.
And the clinical reality demands we treat them differently. I mean, ondansetron works beautifully for the gut serotonin pathway.
Right.
Chlorpromazine blocks dopamine in the brain's CTZ, but then you encounter the vestibular system.
The inner ear, the classic source of motion sickness. Let me ask a highly practical question here on behalf of the listener.
Sure.
If I get terribly seasick on a boat and I decide to take a highly advanced, super expensive ondansetron pill designed for severe chemonausea, what happens?
You will likely continue to be violently seasick.
Wait, really? It would do absolutely nothing.
Pretty much nothing. A gut-level serotonin blocker provides almost no benefit for motion sickness.
Wow.
The vestibular system gets confused when the visual input your eyes are seeing doesn't match the gravitational movement your inner ear is feeling.
Right, the classic boat problem.
Exactly. To intercept that specific neural pathway to the CPG, you need a completely different class of drugs, antihistamines or anticholinergics.
Drugs like mexlizine or scopolamine.
Yes.
Scopolamine is the medication that comes in those little transdermal patches you wear behind your ear.
A lot of people use those.
Sailors rely on them, and apparently NASA relies on them.
Oh, absolutely.
The sources talk about space adaptation syndrome, which affects a huge percentage of astronauts during their first few days in microgravity.
Space adaptation syndrome is essentially cosmic motion sickness.
Cosmic motion sickness, I love that term.
Well, it fits. In the absence of gravity, the tiny fluids and structures in the vestibular system float aimlessly, and that sends chaotic, conflicting signals to the brainstem. Scopolamine intercepts those specific vestibular signals before they can trigger the nausea sequence.
Which takes us to another distinct pathway, the NK1 antagonists, like the drug aprepitant.
Approved in 2003.
Right. We know ondansetron stops the immediate serotonin gut panic on day 1 of chemo, but what about the days after? The sources mention aprepitant blocks a neuropeptide called substance P to stop the delayed phase of nausea.
Yes.
Why does nausea hit days later, and how does substance P factor into this?
Well, while serotonin acts as the immediate day 1 fire alarm, the brain possesses a slower secondary alarm system. Substance P, is a neurotransmitter that slowly accumulates and builds up over the course of several days within the brainstem following chemotherapy exposure.
Ah, so it sneaks up on you.
Exactly. By chemically blocking the specific receptors its substance P binds to, a aprepitant shuts down that delayed phase.
That's brilliant.
It is. Combining a aprepitant with ondansetron and a steroid formed the modern triple therapy, which finally offered comprehensive protection for chemo patients.
And we also have to talk about cannabinoids, like synthetic THC analogs such as dronabinol. This completely debunked a huge misconception for me.
Oh.
Yeah, I always assumed prescribing THC for nausea was a recent alternative medicine trend brought on by modern legalization. But dronabinol was FDA approved way back in 1985.
Yeah, people are often surprised by that. Cannabinoids have a robust, established pharmacological history.
Right.
They work through completely separate CB1 receptors in the nervous system to modulate the nausea response. And, while we are discussing alternative therapies, the pharmacological data shows that ginger is not merely an old wives' tale or a placebo.
Really? I always thought it was just like a soothing tea thing.
No, it actually possesses documented, mechanistically plausible pharmacological effects. That includes measurable 5-HT3 antagonist activity.
Wait, so it acts like ondansetron?
Exactly. It is functionally part of the same pharmacological framework as ondansetron, simply acting as a much weaker, naturally occurring member of it.
That is so cool. And then there's the weird outlier of the group corticosteroids, specifically dexamethasone.
Dexamethasone.
It is used as a booster in almost every intense nausea protocol. It works incredibly reliably, but the notes say scientists still aren't fully settled on how it actually stops nausea.
Corticosteroids remain a fascinating mystery in this field.
Why is it so hard to pin down?
Well, the leading neurobiological theories suggest they might work by reducing widespread inflammatory mediators, or perhaps by directly altering the permeability of the blood-brain barrier near the CTZ.
So tightening up the defenses.
Basically. But it is a prime example of clinical medicine utilizing a drug that demonstrably works, even while the exact molecular mechanism remains fiercely debated.
With all these different drugs targeting all these different pathways, there's an obvious trap here. If a patient is suffering and the first pill doesn't work, human nature says, just take a different one on top of it.
Oh, yes. In clinical pharmacology, we refer to that danger as indiscriminate stacking, or reflective polypharmacy.
Indiscriminate stacking.
Right, because the general public, and sometimes even medical professionals, casually lump these under the umbrella term of anti-nausea pills. There's a temptation to just keep adding different antiemetics if symptoms persist.
Which sounds like a terrible idea.
It is. Blindly adding more drugs together severely amplifies the risk of dangerous side effects without actually increasing the therapeutic benefit.
And we're not just talking about getting a little drowsy either.
No, not at all.
The notes emphasize serious risks like extrapyramidal symptoms. Can you break down what that actually looks like for a patient?
Extrapyramidal symptoms are severe involuntary motor control issues.
Yeah.
Because drugs like chlorpromazine block dopamine, which is essential for smooth muscle movement, stacking them, can cause patients to develop sudden muscle spasms, facial twitching, intense restlessness, or even full Parkinsonian tremors.
Oh, wow. That is terrifying.
It's very serious. Indiscriminate stacking only works if it is guided by strict, evidence-based combinations that target entirely different pathways intentionally, like the triple therapy we discussed for oncology.
So the stakes of getting this pharmacology wrong are incredibly high.
Extremely high.
And that brings us to the dark side of antiemetics. Because the desperate human need to stop nausea, especially in vulnerable populations like pregnant women, has historically led to some of the most profound tragedies and fierce regulatory battles in modern medical history.
We absolutely must address thalidomide here. It is the single most vital cautionary tale in the history of pharmacology. It's taught in every medical curriculum around the world.
Thalidomide was aggressively marketed in the late 1950s across Europe and Canada.
Right.
It was initially a sedative, but pharmaceutical companies quickly realized it stopped nausea, and they heavily promoted it as an over-the-counter miracle cure for morning sickness in pregnant women.
But the clinical results were unimaginably devastating. Thalidomide severely disrupted fetal blood vessel development. It caused a specific condition called phocomelia.
What does that present as?
It presents as profound limb malformations, where infants are born with severely foreshortened or entirely absent arms and legs. It caused this alongside other catastrophic internal birth defects, in an estimated 10,000 to 100,000 children worldwide before it was finally pulled from the market in the early 1960s.
And the only reason it did not cause widespread generational tragedy in the United States was because of one single FDA reviewer, a pharmacologist named Francis Kelsey.
A true hero.
The manufacturer applied immense, relentless corporate pressure on her to approve it quickly, pointing to its widespread use in Europe. But she held her ground. She repeatedly refused to sign off because the safety data regarding pregnant animals simply wasn't there.
Her principled refusal saved thousands of American lives.
Unbelievable courage.
Really. And thalidomide became history's starkest, most painful lesson that just because a drug is highly effective at stopping a symptom does not mean it is systemically safe.
Right.
It permanently and radically altered global drug approval standards. It directly forced the passage of the 1962 Kefauver-Harris Amendment in the U.S.,
Which changed everything.
fundamentally changed the FDA's mandate. From that point on, pharmaceutical companies were legally required to prove rigorous scientific evidence of both absolute safety and clinical efficacy before any drug could be approved.
But the traumatic fallout from the thalidomide disaster created this massive, chilling regulatory whiplash. Because the sources detail what happened next with a totally different morning sickness drug called bendectin.
Right. Bendectin was a simple combination of doxylamine and antihistamine and vitamin B6.
Very standard stuff.
Through the late 1970s, it stood as the sole FDA-approved medication for morning sickness in the United States. Millions of women relied on it.
But in 1983, the manufacturer voluntarily pulled it from the market. And the kicker is, they didn't pull it because of bad science.
No.
There was absolutely no credible epidemiological evidence linking bendectin to birth defects. They pulled it purely because the sheer financial cost of defending themselves against a wave of fear-driven lawsuits became too expensive.
And the withdrawal of bendectin left pregnant women in the United States with absolutely zero FDA-approved antiemetic options for morning sickness for 30 years.
30 years.
Yes. It is widely cited by public health researchers as a profound failure of the system, where legal pressure and public panic, rather than rigorous scientific evidence, dictated medical availability.
That is just wild.
It wasn't until 2013 that the FDA finally reapproved the exact same chemical combination under the new name NCLEX.
And we saw a similar kind of regulatory whiplash with a drug called droperidol, too. It was a highly effective, widely used drug for postoperative nausea. Anesthesiologists relied on it for decades.
Oh, heavily relied on it.
Then, in 2001, the FDA suddenly slaps their most severe warning, a black box warning on it, citing risks of fatal heart arrhythmias, specifically something called QT interval prolongation.
Right. QT interval prolongation is a severe cardiac issue where the heart's electrical system essentially takes too long to recharge between beats.
Okay.
And that opens a dangerous window for fatal arrhythmias to occur. Following that black box warning, the clinical use of droperidol collapsed almost overnight.
But the anesthesiology community fought back, right?
So they fiercely debated the FDA's decision. They argued the warning was heavily skewed by a small number of case reports where psychiatric patients were receiving massive, continuous doses. Doses far exceeding the tiny single doses used to manage nausea in surgery. It's often viewed as an example of regulatory caution, entirely outrunning the nuanced underlying data.
So, what does this all mean? We went from a tragic, catastrophic lack of regulation that caused the thalidomide disaster to perhaps overcorrecting out of sheer institutional fear with bendectin and droperidol. How do doctors today navigate all that historical and legal baggage when a patient is sitting in front of them, actively suffering and needing relief?
If we connect this to the bigger picture, it perfectly explains why major clinical guideline bodies like the American Society of Clinical Oncology or the Multinational Association of Supportive Care in Cancer are constantly and meticulously revising their protocols.
Keeping the data fresh.
Exactly. Modern medicine navigates this historical baggage by clinging fiercely to large-scale data. Physicians must continually calculate a complex equation. They are balancing the very real side effect burdens like cardiac risks, extreme sedation, or motor tremors against genuine, often life-saving therapeutic needs.
And those needs are so incredibly grounded in the reality of everyday life for millions of people. We're not just talking about abstract molecular science in a lab.
No, this is daily clinical practice.
These medications dictate whether roughly a third of all surgical patients wake up comfortably, since postoperative nausea remains a massive complication.
They are the ultimate deciding factor in whether cancer patients can physically tolerate the rigorous chemotherapy regimens required to cure them.
Right.
Uncontrolled nausea is consistently reported by oncology patients as one of their most severely feared side effects. It frequently ranks even higher than hair loss or fatigue.
And they are absolutely essential for managing severe conditions like hyperemesis gravidarum.
Yes.
That's the relentless, severe pregnancy-related vomiting that famously hospitalized Catherine, Princess of Wales. Her very public case really brought mainstream attention to how deeply debilitating and dangerous pregnancy vomiting can be.
It's not just morning sickness.
No, it often requires prolonged hospitalization, IV fluids, and heavy prescription antiemetics just to prevent organ damage from dehydration.
And as we touch on with NASA, these precise pharmacological tools even allow humanity to explore space, safely mitigating that profound vestibular disruption astronauts endure in orbit.
It really is a triumph of modern pharmacology, painstakingly mapping out this incredibly complex alarm system, tracing the wires from the inner ear down to the gut, all the way up to the brainstem.
And yet, there is still so much we don't fully understand. Think about how incredibly varied these triggers are.
Oh, completely.
Your body can initiate this violent, systemic, full-body response from a microscopic toxin in your blood, from a sudden, localized flood of serotonin in an irritated intestine, from a shift in gravity in your inner ear, or astonishingly, even just from the visual memory of a hospital room stored in your higher cortical centers.
It's an ancient alarm system that is hardwired into almost every single aspect of our physical and psychological existence.
Which leaves us with a genuinely fascinating thought to mull over.
Okay, what is it?
If our human bodies evolved this incredibly intricate, widely distributed neural network purely to protect us from accidental ingestion and environmental threats, what does that say about the sheer staggering complexity of our evolutionary survival mechanisms? And if we can eventually unlock the final mysteries of nausea, like exactly how a steroid like dexamethasone somehow calms this entire system down at a molecular level, could that breakthrough eventually teach us something entirely new about how human consciousness itself intercepts, interprets, and ultimately processes physical threats?
It definitely makes you look at that old, simple X-ray machine a little differently. Maybe the diagnostic waters of neurophysiology are murky, not because our scientific tools are bad, but because the human body is just that much more beautifully, frustratingly complex than we ever imagined.
Beautifully complex is the perfect way to put it.
Well, thank you for joining us on this deep dive into the pharmacology of antiemetics. We'll catch you and your newly informed perspective on the vagus nerve next time.